Welcome to ADEF.
Today, we're diving deep into a clinical scenario we all face. What's the next move when a patient's triglycerides are still stubbornly high, even when you've done everything right? We're going to walk through the 2021 ACC expert pathway to get some clear answers.
So here's our game plan. First, we'll set the stage and define the challenge. Then we'll cover the core management algorithm that applies to everyone. After that, we get into the specifics, therapies for high-risk folks with ASCVD and diabetes. Then we'll switch gears completely to talk about severe hypertriglyceridemia. And finally, we'll pull it all together to look at our treatment landscape.
All right, let's jump in. We're starting with a question that probably sounds very familiar, one that really gets at the heart of managing that leftover or residual risk after we've already gotten LDL cholesterol under control. And that is the exact question, right? The one the ACC pathway was really built to answer. It's designed to make us look beyond just LDL and to start thinking strategically about the significant cardiovascular risk that high triglycerides represent.
Okay, first things first, we need a really clear definition. The pathway isn't talking about just any random high triglyceride reading. We're focused on persistent hypertriglyceridemia. And that term only applies after you've put in the work. We're talking 4 to 12 weeks of lifestyle changes, getting them on the best statin dose they can handle, and ruling out other causes. This is huge because it gives us a clear line in the sand for when we should escalate therapy.
So before we even think about adding another drug, the ACC is crystal clear on this. There are 3 foundational pillars that have to be rock solid. These are absolutely non-negotiable for every single patient. And here they are. Step 1, intensive lifestyle changes. Step 2, a real deep dive to find and manage any secondary causes. And step 3, making sure that statin therapy is truly optimized. These aren't just suggestions. They are the absolute bedrock of triglyceride management.
You know, this table really drives home just how wide we have to cast our net for secondary causes. Of course, as endos, things like poorly controlled diabetes or hypothyroidism are our bread and butter. But look at this list. We've got common drugs on here, thiazides, beta blockers, even atypical antipsychotics. Not to mention CKD, obesity, the whole shebang. We have to be detectives here. Ruling this stuff out is absolutely critical. And let's not forget how powerful the statin itself is. Yeah, we think of it for LDL, but a good statin regimen can knock triglycerides down by 10 to 30%, and it's dose dependent. That's a pretty significant effect all on its own, and it's exactly why maxing out the statin first isn't just a suggestion. It's step 1 of pharmacotherapy. All right, now we get to the real meat of the pathway. What do we do for our highest risk patients? I'm talking about those with established cardiovascular disease or diabetes who are sitting with triglycerides in that moderate 150 to 499 range. For a patient who already has ASCVD, the pathway gives us a beautiful, simple branch point based on their on-treatment LDL. If their LDL's already looking great, below 70, the data from Reduce-It says we should think about adding icosapent ethyl. But if that LDL is still up at 100 or higher, the priority has to be more LDL lowering first. That means reaching for ezetimibe or maybe even a PCSK9 inhibitor. Okay, and this is where it gets really compelling. The data for icosapent ethyl in this group is just, wow. Let's look at the number. In the Reduce-It secondary prevention group, the number needed to treat to stop one major cardiovascular event was only 16. Just 16. In clinical practice, that is an incredibly powerful statistic. It really makes you sit up and take notice.
But, the guidelines are also refreshingly honest about what we don't know. And there's this gray zone, the patient whose LDL is between 70 and 99. Here, the evidence is a bit thin. Do you double down on LDL lowering, or do you go with IPE? The pathway doesn't give a hard and fast rule. Instead, it frames it as a perfect moment for a shared decision-making conversation with your patient.
Now, for our primary prevention folks with diabetes, the recommendation for icosapent ethyl gets a little more specific. The evidence from Reduce-It really supports its use for patients who are 50 or older and have at least one other ASCVD risk factor hanging around. Outside of that specific group, the evidence is a bit weaker, so the focus should really stay on that foundational care we talked about.
Okay, let's pivot. We're moving into a totally different clinical world now, severe hypertriglyceridemia. When you see these numbers, the entire game plan changes. This is an urgent situation. And this is the magic number to remember, 500. Once a patient's fasting triglycerides hit 500 milligrams per deciliter, our primary focus is no longer just about long-term cardiovascular risk.
At this level, the goal shifts. It's all about one thing, preventing acute pancreatitis. As those numbers climb, especially as they get near or over 1,000, the risk of this awful, painful, and sometimes fatal complication goes way up. Our immediate job is to get those levels down to prevent a crisis. And that new goal demands a whole different level of lifestyle change. Just look at the diet recommendations here. When triglycerides are over 1,000, we're not just suggesting they cut back on fat and sugar. We're talking about a very, very low-fat diet, like 10 to 15% of calories, and completely eliminating added sugars. This is crisis management, plain and simple. The pharmacology flips on its head, too. Now fibrates jump to the front of the line. They are our first-line agents because of their powerful triglyceride-lowering effect. Prescription omega-3s are an excellent second-in-command, and you can absolutely use them together if you need to get that pancreatitis risk down fast. And if the worst happens and your patient shows up at the hospital with hypertriglyceridemic pancreatitis, we bring out the heavy artillery. We're talking about things like an insulin infusion to fire up lipoprotein lipase and clear those triglycerides, or even plasmapheresis or hemofiltration to literally pull the fats right out of their blood. Okay, let's wrap this up by putting all the pieces together. Think of this as a practical summary of all the tools we have in our toolbox for managing high triglycerides. This chart gives you a nice, clean, at-a-glance look at what to expect. Fibrates are our heavy hitters, no question, giving us a 40 to 60% reduction. Prescription omega-3s deliver a really solid 20 to 30% drop. And niacin is in that same ballpark, though, as we all know, its side effects can make it a tougher sell.
And when we start combining these, safety is everything. A key rule of thumb, if you're putting a fibrate with a statin, you really want to use fenofibrate, not gemfibrozil, because the myopathy risk is much lower. We also know that adding icosapent ethyl to a statin is a well-supported move. And for those severe cases, don't hesitate to combine fibrates and omega-3s to slam that pancreatitis risk down.
So at the end of the day, the ACC pathway gives us this amazing evidence-based roadmap. But the final step, and really the art of what we do, is pictured in this question. It's on us to take these clear guidelines and personalize them, to tailor our approach to manage both that long-term cardiovascular risk and the immediate danger of pancreatitis for every single unique patient that walks into our clinic.
At the conclusion, Dr. Bao will present the latest developments in FCS.
Endocrinologists will see the ultra-rare genetic disorder Familial Chylomicronemia Syndrome, or FCS. For these patients, the threat of pancreatitis isn't a risk, it's a constant reality.
The road for these patients is just brutal. They often face years of being misdiagnosed and stigmatized. I mean, this quote just says it all. They get blamed for their condition, accused of drinking too much or not following a diet, when the reality is they have a genetic disease that simply doesn't respond to the usual treatments.
So what is FCS? Well, it's caused by genetic defects that basically cripple lipoprotein lipase, the enzyme that's supposed to clear triglycerides from your blood. The result is these astronomical triglyceride levels, so high you can sometimes see the fat in their blood, making it look milky. And our standard toolbox, statins, fibrates, they just don't work. This leaves patients with only one tool, a diet with almost no fat, which is profoundly difficult to live with day in and day out.
For these patients, for decades, the therapeutic toolbox has been completely empty. They've been trapped, trying to manage a life-threatening disease with diet alone. But after all that waiting, the landscape is finally, and I mean finally, changing. And that change is coming from a totally new class of drugs. Olezarsen is a perfect example. It's an antisense oligonucleotide, and it works by targeting something called apolipoprotein C3, or ApoC3. Just think of ApoC3 as the natural brake on breaking down triglycerides. So what Olezarsen does is it inhibits the production of that brake. It takes the foot off the brake, allowing the body to clear triglycerides much more efficiently, even in patients who have that faulty LPL enzyme.
And the results are just wow. If you look at the data from the Phase 3 BALANCE trial in patients with confirmed FCS, you see this really clear dose response. The 80 milligram monthly dose cut triglycerides by a median of over 43% at 6 months. That's a huge, clinically meaningful drop compared to placebo.
But honestly, this is the number. This is the one that really matters. All that triglyceride lowering translated into a staggering 88% reduction in pancreatitis attacks over the course of the trial. An 88% drop. That is a life-changing number for these patients. It's the outcome that can give them their lives back.
So the arrival of these ApoC3 inhibitors like Olezarsen and some other new drugs in the pipeline, it's not just an improvement, it's a true paradigm shift.
For the very first time, we have a targeted, effective drug for our patients with the most severe, genetically driven forms of this disease.
Which, of course, leads to the big questions, right? How are these new drugs actually going to change your practice? How do we pick the right patients? What does the dosing and monitoring look like? How do we fit these powerful new tools into the care pathways we already use?
And those questions, all those practical details, they deserve their own deep dive. So join us for our next explainer, where we will get into the nitty-gritty of putting these new therapies into practice, the patient selection, the dosing, the monitoring, all of it. Thanks for joining us.